This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hi, I'm Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon with a specialty in ear and skull-based surgery, practicing in New York and New Jersey with ENT and Allergy Associates. See, Marina, I changed up my intro.
I know. You make me laugh all the time. I love it. I'm Marina Kurian. I'm a general and minimally invasive surgeon. I do a lot of weight loss surgery as well as medical weight loss in New York City. So welcome to She's on Call.
Yeah, we're so happy that you're here with us. We have two wonderful guests today. You might have noticed that our background, instead of being blue, is pink today.
That's right. And it is Breast Cancer Awareness Month. And so we have taken one of the she schemes.
That's right. And today we're going to do a show all about radiology, all about the magic that is there in x-rays and MRIs and angiograms and mammograms and sonograms. And our guests today are Dr. Agnieszka Solberg and Dr. Kattapuram. And they are both radiologists and passionate advocates for gender equity in radiology and in medicine via their group, which is at Radiology Chicks.
You know, you said magic in radiology, and you know it's true. The great thing about medicine is that it really is a lot of teamwork. It might seem like we kind of have turf wars and struggles and stuff like that, but radiology is so integral to what we do. In every field, right? I don't think there's one field where radiology isn't completely necessary. So if you have, we can palpate or feel lumps and bumps, but sometimes we need to see what else is going on. And so we'll get an x-ray and a special type of x-ray depending on the region of the body that we're working on. And because of that and the images that are shown, we're able to get a lot more information. But you know why I started down this road of lauding my radiology people, as you said, the magic of radiology, and I was thinking, it's like shadows. They're shadow readers, you know what I mean? It's like different shades of gray, and they're like, no, that's this, and you're like, okay.
Well, okay, so because my personal hero is Marie Curie, the X-rays were called X-rays because neither she nor Henri Becquerel nor Pierre Curie, who shared that first Nobel Prize, knew what was causing these magical X-rays. He had put a plate of what ended up being film in a drawer with his wife's ring, and that cast a shadow on the plate. So that's actually how this field started. There's been Nobel Prizes for MRI technology, and they really have changed the way we take care of patients. So if you want to learn more, or you want to spend some time with two amazing guests that we have today, please tag and your friends and like and share and let people know that we're on now. Send in your questions, send in your comments. We're really happy to engage in a dialogue with you. But first, we're going to start with the news. And man, oh man, was there news this week, Marina.
Yes, there was. Unfortunately, many people in our government, including our president, have gotten COVID, and as well as a member of his family and his close aides and some of these people that attended what we're calling what's been called a super spreader event that happened in the Rose Garden on September 26th, so just a few days ago. And someone there must have had COVID. Nobody was wearing masks, and unfortunately, you can see how close they were. But these were the people that we knew were positive as of I think
yesterday. Really, yeah. There were 100 people there. The vast majority were not wearing masks, and all the pictures show that not only was there no social distancing when they were sitting, but they were also then hugging and handshakes and talking closely and, you know, talking above the din of the crowd. And the more you're projecting your voice, the more aerosols are released into the air, so that even though it's outdoors, it's not safe if you're just very close to each other. President Trump was airlifted over to Walter Reed Medical Center, walked to the transport of his own accord, apparently has received both remdesivir and an infusion of an experimental neutralizing antibody cocktail made by Regeneron. Both of these agents have received EUA, or expedited use authorization, from the FDA, and he's also taking a number of vitamins and minerals. And we certainly wish all of these people well. But in the picture, we showed you some pictures from the Daily Mail in the United Kingdom and from the New York Times, and you can actually see the location of many of the people who contracted the virus. So you see President Trump at the podium, and in the front row was Mrs. Trump. Right behind her was Kellyanne Conway. Another row behind was were some of the Congress people, senators. John Jenkins is the president of Notre Dame University. Senator Mike Lee is sitting right behind Vice President Pence, who apparently is negative for COVID right now. Senator Tillis was in that same row as Senator Lee, and former New Jersey Governor Chris Christie is off to the left of Judge Amy Coney Barrett and her family, who are also in the front row with Mrs. Trump. So this is a very, even though they're outdoors, they're actually quite close together. So let's talk about what we should do. Why is it, Marina, that we're asking not just you to wear a mask, but me also to wear a mask? Let's talk about what this does.
We're not wearing masks.
Yeah. Let's say we were actually ever together, we would both be wearing masks.
You know what? If you guys, this is not from me. Okay, I found this on the internet, but the super spreader events occur in areas of limited ventilation. They occur at venues, and they occur because of vocalization, right? So now we always talk about the 3 W's, which I'm going to let Suju talk about in a minute, but there's apparently 3 V's, which is venue, which is why the bars are not open, or we're starting to go inside, but limited. Ventilation is important. It's why the gyms weren't open until they had to have, at least in New York State, appropriate filtration and air movement. And then vocalization, where you're not singing at like a concert or at a rock venue, and you're not, in an enclosed space. So people that were at the Rose Garden, they were talking. There had to be everyone. When they were socializing, people had all these different conversations. So automatically you're raising your voice, you're leaning in to hear what the other person is hearing. And I think that is why things went to this level. And I think that this is something that doctors, scientists, and people who understand transmission of particles and aerosol, and how air travels, and you guys were watching that wear masks. You kind of had an idea, right? So this, unfortunately, is really showing us what happened. Can we go back to that image, Suju? You want to talk about that?
Let me talk about that image again. And what we're showing you is sort of what happens if the person on the left is carrying SARS-CoV-2, which is the virus that causes COVID-19. So if the person on the left is carrying it and is talking to the person on the right, and neither has a mask, it's a very high rate of spread. This is a highly infectious virus. If the infected person is talking without a mask, but the other person has a mask, they've only reduced their risk of catching it a little bit. So it's still a high risk. If the person with the virus is wearing a mask, but the person they're talking to is not wearing a mask, it's sort of a medium risk. It's a better protection of preventing the virus from getting too far into the air. If both are wearing a mask, it's a low risk. If both are wearing a mask and standing 6 feet from each other, it's a very low risk. And obviously, if you're inside your home with the windows closed and the contagious person decides to walk outside without a mask, there's no risk of you getting the disease from them. But this is why it's actually important for both parties to wear a mask. Not because it's very few people were wearing a mask, but in fact, one of the people who did contract the virus at the Rose Garden was wearing a mask. So that tells you that that does not protect you as well as if both people are wearing a mask. So the 3 W's we talked about. Oh, no, before we do that, I want to say that there's an incubation period, right? So you get the virus and then you're really not sick for a little bit and then you get sick. And in that incubation period where you don't know you have the virus, you are actually very contagious. So that's why wearing a mask when you don't feel ill is the correct way to do it. And the normal course of this disease is about 80% will get better. We'll have a self-limited, very minimal course, but the 20% can take a bad turn. So they can need hospitalization, they can need supplemental oxygen, they can need steroids if their breathing is labored. And if they end up in the intensive care unit, about half the people that in the last 10 months, we've discovered about half the people who end up in the intensive care unit with COVID-19 will die. So this is, for the most part, self-limited, but we can't predict who's going to get really sick and die from it. We can tell you if you're older and if you have comorbidities like diabetes or high blood pressure or underlying lung disease or obesity, you have a higher rate of going in the wrong path, in the more sick path from COVID.
Couldn't agree. So I couldn't agree with you more. And it's about a 3% risk of death if you have one of these comorbid conditions, like that you mentioned already. High blood pressure, diabetes, obesity is one as well. So definitely something that we have to, continue to wear the mask right now until the vaccines happen, which is not going to be, this quarter at all.
So, wear a mask, wash your hands, watch your distance. And this really holds true for all of us. Thank you, guys. People are watching from Delaware. People are watching from White Plains. People are watching from California. People are watching from Boston. Thank you guys so much for watching. We're going to learn so much from our guests and learn a whole lot of stuff about not just radiology, but also gender equity in medicine and their journeys as they moved along. We want to mention a little bit about long COVID because it's not either you are fine or you die. There's a middle group that is really being affected, Marina.
Yep. So 10% of patients who get COVID, so you said that 80% of them will have mild symptoms, right? But if you look at the 100%, or the 100% of people who survived, 10% have something called, what they're being called long haulers. So they're having symptoms that are lasting weeks to months. And I just had a patient that I saw who got COVID in March, and she still has extreme fatigue and has some issues with her lungs where she's been on steroids for the past month. And normally, and you guys who are watching, you know that if you've experienced this yourself, that if you get like a bronchitis or if you have a history of asthma and you have bronchitis or some exacerbation of the asthma, you go on a short course of steroids, like anywhere from 3 to 10 days. Like this patient, she's been on it for the past month. So you can see that her symptoms are really kind of devastating and frustrating for her. It's affecting her mood, and not only on top of that, she's quarantined. She's still able to work, and she's working from home, so that's great. But in addition, she's experiencing weight gain from the steroids. So it's a terrible situation. So the long haulers, the good thing about that is there are clinics popping up all over the country. You guys heard it here first that, Mount Sinai had a long hauler clinic. I don't think they're calling it that now, whatever they're calling it. But there are major academic and also non-academic community centers that are trying to take care of these patients. But just to note, in the US, there are 7.5 or almost 7.6 million coronavirus cases. That means that there's going to be 760,000 patients that have lingering symptoms that now are going to be turning to the healthcare system for treatment. And so it's still a health crisis, right? It's still a burden on our health system. And that's not going to go away anytime soon.
Yeah, we actually had a show where we talked about this with Dr. Monica Verduzco Gutierrez in San Antonio. She's a physical medicine and rehab doctor. And to learn more about long haulers, I learned a lot from her on that show. So I recommend you guys go back and see it. But now it's time to introduce the main event.
Yep. So we're so happy to have two wonderful radiologists with us, Dr. Agnieszka Solberg, and you see her Twitter handle at Agnes Solberg, and then Dr. Kattapuram, and she's at Taj Cat. Welcome, you guys. They do different things. We're going to get to talk to them because about radiology, but also what different aspects of radiology they are. So they're actually specialists within the field. So welcome.
Thank you for having us.
Thank you so much for having us.
It's great to have you both aboard. Agnes, you are clinical assistant professor of radiology at University of North Dakota School of Medicine, and you are chief of medicine and radiology at CHI. Is that right? St. Alexius?
CHI, I was.
Oh, okay. And you're a vascular and interventional radiologist.
Correct.
Very cool. And you also served in the armed forces.
Yep, I was in the Army. All my medical training was most of it was in the U.S. Army.
That's wonderful. And Taj, you are a radiologist in Colorado, and you're
you, right?
See again?
You know people at Walter Reed then.
I was there. The old Walter Reed. This is the new Walter Reed.
Yes, this is the combined Walter Reed. Taj is a radiologist in Colorado. Her specialty is breast imaging and interventional radiology. And these two women are both really active in their fields and really active with outreach to younger radiologists, to women in their field. And they really are role models for us to follow. So what we wanted to talk about is, let's start with Breast Cancer Awareness Month. We have people watching, as I said, from all over the United States. We have people who just checked in from Nicaragua. We have people watching from India. In the US, October is designated Breast Cancer Awareness Month. And it is a good time for women and men to remember that this disease can affect them. 1 in 8 women in the United States will have breast cancer in the course of her life. And so this is a disease where if we catch it early, the prognosis is really good. I remember when the actress Julia Louis-Dreyfus announced her breast cancer on Twitter, she said, well, it happens, I think back then it was 1 in 9. She said, I'm one of those 1 in 9. And it's sort of a course of events where you just catch it early, take it seriously, and carry on. So
I want to say, when I was in med school, and also when Suju was in med school, it was 1 in 11. And I still thought that was like super high, right? So while there are changes and better techniques to catch breast cancer early and treat patients early, it seems that number has changed. And, I wonder if it's because we're catching cancers earlier and that's why the number changed, or if breast cancer is the disease itself is changing. Todd, what are your thoughts?
Absolutely. So in just the last 10, 15 years, we've seen remarkable improvements in technology, and we're even having some current changes that will become the norm very soon. So just talking about the last 15 years, we have better techniques for biopsy and imaging-guided biopsy. So that has been able to detect baseline cancerous, the DCIS, or precancerous, the atypical cells pretty early. And now more recently, in the last 5 to 10 years, we've seen the development of 3D tomosynthesis mammography. And that has increased our ability to detect cancers even earlier, because we can now almost scroll through the mammographic image, whereas before it was two plain films. We can now flip through it almost like a book, and that has been able to expose some cancers even earlier. And currently, which hasn't been quite integrated into our systems yet, but currently we're developing technology in the realm of artificial intelligence. And so I'm sure that will even help us catch breast cancers even sooner. So absolutely, the latest in technology, the dedicated fellowship trained breast radiologists, et cetera, all of that with artificial intelligence, we're able to detect even sooner. So that is why you're seeing a number from 1 in 11 now increase to 1 in 8 for sure.
So, I want to talk about artificial intelligence for a second, because it sounds creepy. Because movies are always creepy. It's never like a good thing, like
Yeah.
AI,
Terminator.
Right. There's so many of them.
Right.
There's actually one called AI, but artificial intelligence was really it's like having Watson, the supercomputer, look at images and try to find patterns and identify whether it's shading or shadows, as I said before, but like different changes that can either predict early disease or identify actual disease. And so it's being used in radiology. It's actually also being used in pathology. So in medicine, I think that we're all safe and we're still going to have jobs, but hey, a little concerning. But if you could just kind of describe how the AI is functioning, and then after, we'll put up that picture of a 2D breast image and then a 3D, because I think that once you describe what the AI is doing, then we'll make a little bit better sense of that picture.
Oh, I think we might have lost Dodge.
Oh.
Yep, Dodge might have exited.
Lost. That's okay.
Before she comes back, or while we're waiting for her, Agnes, you do interventional radiology, which is sort of next level. But let's start at the beginning. So let's start with plain X-rays. Then if you can describe to our audience and to us, what's the difference? What's the difference between a plain film, a CAT scan, an MRI scan, and then a functional MRI, and then maybe what you do with interventional or with an angiogram?
Sure, of course. So an X-ray or a plain image, a plain film is essentially X-rays being passed through your body. There's a detector behind you, and what doesn't pass generates the image. The CAT scan is the same technology, but it spins around you and reconstructs in three-dimensional image. Both X-rays and CT scans are based on density. So on your image, something that's more dense like bone will be white, and air will be black, and then various things in between have different shades of gray, and that's what provides our contrast in X-ray and CT imaging. MRI is based on essentially a magnet. There's a magnet applied, and a lot of fancy physics things happen, but the bottom line is that it all has to do about how the charges in your body relax, and that's pretty much, the rest is beyond the scope of this presentation. MRI doesn't make a good hobby. Pretty complex, and the technology is truly advancing in what we can image. There are limitations with essentially every modality that we have. We have sonography or ultrasound, which uses sound waves to make a two-dimensional or even now a three-dimensional image, which is mostly used with fetal MRI. You can see part of the baby's face, etc. And so with as far as the functional, any of these modalities can have a functional or physiologic component to them. So with CT and MRI, for example, one of the examples is perfusion. So we can actually watch the blood, how you can see how quickly the blood goes into a certain part of the body, for example, the brain. And when somebody's having a stroke, we can identify tissue at risk. So this is essentially a perfusion CT scan that you can see on the screen. It's not an MRI, it's a CT. And this is essentially the amount of contrast. The pink area is the brain that is completely dead, and the green is an area that's at risk. So for this particular patient, you can see that the area at risk is much larger. That's called the penumbra. It's much larger than the core infarct, or that little pink area, the dead area. And so for this patient, it makes sense to try to get the clot out, to take him to IR get the clot out, because this patient can get improvement. And this patient actually did get improvement and came into the ER not being able to walk at all, wasn't able to speak, and left walking and speaking. 2 days later, did not even qualify for rehab. And so this is how we can use imaging and provide interventions and really help patients.
That's amazing, right? It's an amazing thing. If you come in with a vascular lesion and you walk out, you literally walk out. You're not debilitated significantly by such a significant hit to the blood supply of the brain. We do have a picture of the angiogram from a similar patient. Do you mind showing it and telling us what this is showing?
Yeah, so essentially an angiogram uses X-rays, and what we do is we inject contrast into the vessel, and it takes essentially each image is at least 2 X-rays. It's a X-ray with that before the contrast was injected, and then after the contrast, and then the computer subtracts the 2 images. That's called digital subtraction angiography, and that way you only see the blood vessel. So this image there's 2 different images. On the left, you can see there is a big chunk of brain missing compared to the right, and this is the same patient. So on the left, that entire middle cerebral artery territory was not getting any blood. That's the part of the brain that makes you walk, talk, move, etc. And after this was just 1 pass of aspiration, the flow was completely restored, and this patient walked out of the hospital.
So can I, just for our audience and for me, when you say aspiration, that means you sucked out a blood clot? Is that what you're saying?
Yeah, it's like a heart catheterization, but we catheterize every part of the body except for the heart in interventional radiology. The cardiologists have the heart. So this essentially, went through the groin, through the common femoral artery, and threaded the catheter all the way to the brain, and literally aspirated the clot out, yes, with the catheter.
That's amazing. That's really wonderful. And so this patient leaves capable of doing their normal activities afterwards. We are live on all the social media channels, Facebook, YouTube, LinkedIn, Twitter, Scroll.in. Please like and tag your friends who are interested in learning from smart women. And please let them know, and please send in your questions and comments. Let's go back to Taj for a second. We had been talking about the difference in mammography from 2D to 3D, so mammograms. 1, why do you have to squish our breasts so hard? And 2, can you tell us what you're looking for when you look at these pictures?
To squeeze the breast so hard with a lot of force, but the reason we do that is because it helps spread out the tissue, for 1, and number 2, it reduces motion by holding the breast pretty still. So as you can see on the image, you have or on the screen right now, you have a picture of a mammogram, and that circle is showing a spiculated mass. And that is an example actually of a 3D image. So you can sort of see it in the 2D image that's adjacent to the circled picture. But this 3D image really helped scroll through the breast tissue and really helped highlight that there was something in the breast tissue causing a little bit of distortion. And I forget, what was the second question?
So I was asking you what you see. So then if the patient has this finding, I know that a lot of times radiologists such as you will do the biopsy, will do either a fine needle or a core needle biopsy. And I wonder if you can describe to our viewers what that is and how you do it.
But wait, before you do that, can you talk about this 3? I'm probably due. I think I'm due in December or something to go get the boob smashing event. But does 3D, do you have to do the same thing? Do you have, or is there a way to do it that it's not so smashed? You know, it's painful, right? And and also our insurances, like, I know that we are an international show, so it may not come to play in other parts of the world, but in the US, it's just going to be like automatically a covered thing to get the 3D, because clearly the image is actually better. And even I saw the lesion. I was like, there it is. I found it, so.
Absolutely. So, unfortunately, yes, 3D is currently the same protocol as performing a 2D image. The only difference is that on the actual scanner itself, it's the scanner that moves around the patient. But we do need patients to hold still. It's very similar almost to the CT scan. When you roll through the donut, the scanner is moving around that donut, but the patient is holding still while they're lying on the table. So yes, we do have to put some force on the breast tissue to do it the 2D way. And as far as 3D being covered by insurance, we're working on that. Right now, a lot of the legislation is at the state level, and many of the insurance coverages, it starts with first awareness. So we're bringing awareness to a lot of women at the state level by passing legislation on breast density. So you've probably heard about these breast density laws. And as women become more aware of what is their breast density, especially if they have a lot more connective tissue as opposed to fatty tissue, they can then be educated that the 3D technology is going to be better for them. And then we are able to then start pushing legislation to have private insurers cover 3D technology, as well as any supplemental screening with MRI or whole breast ultrasound, et cetera. So we're working on it, and hopefully one day it'll be federal legislation, but we're already very blessed that Medicare fully approves it and covers it, and our patient population tends to be in that age range. But of course, we do recommend screening beginning at age 40.
So that's really very helpful. I think, this speaks to the fact that physicians, whether we want to or not, end up being social justice warriors for our patients, fighting for coverage for the things that will keep our patients healthy. So Agnes, Robert Hillman, who's watching from, I'm going to say North Carolina, Robert, is asking about how you get from the groin to the brain. Is it a straight shot? And I think the answer is no. How do you manage to do that?
So essentially, by knowing the patient's anatomy, most of us have standard anatomy, although many patients have certain variations. But it's pretty easy in most patients to get up to the aortic arch. In other words, to the big artery in the chest, and then that is where the vessels to the brain take off. The older the patient is, the more difficult it is to get into the brain, especially on the right side, just because of the way that the plumbing is connected, so to speak. But the way that we do it, essentially, it's like making your way through plumbing, through arteries, by using a catheter and a little very soft tipped wire with a little curve on it. And that's how we turn into one pipe versus a different pipe.
And so this is an image that Marina found. She actually scrolled looking for interventional radiology pictures, and I think after 30 pictures, she finally found an image of two women interventional radiologists, and that's something we're going to talk about in a little bit with both of you. But you can see that the catheter, I think, is being introduced into the groin here, and then you're using what, X-ray or fluoroscopy to kind of thread it up the pipes?
Yep, fluoroscopy is essentially X-rays. That is actually a syringe, and you would never hold it that way. I'm guessing this is a stock image of actors.
No, it was actually from. It's funny because it was from one of the hospitals, and they said,
"Oh, really? Maybe they're flushing the sheath." That's the only explanation I have. But that is exactly the machine I have, the Artis Z, which is interesting.
It could have been you. That's what I was going for. No.
Wow, there you go.
So this is so that you can thread up the catheter without obviously puncturing the blood vessel or going in the wrong direction, correct?
Well, sometimes you do go the wrong direction, and so you pull it back a little bit, and then you turn the wire or catheter, because they both can be curved, and you try to make it go the other way. I know that seems. It's hard to explain how it's done. A lot of it is by feeling things, and then also I'm watching it on the screen live as I'm trying to advance the catheter and wire forward.
I think a lot has to do with how we are trained and how, you were trained by your seniors and how you go on to train others and kind of hold their hands metaphorically as they do this so that they can go forward and take care of more patients. We do have a question about ultrasound. And so somebody called Stalwart is saying, my wife has fertility issues and they keep doing ultrasounds. Are these tests bad for the body if they're done frequently? And what do ultrasounds show us? Maybe we'll ask Taj.
First of all, to Stalwart, you don't have to worry about your wife getting frequent ultrasounds. We do a risk benefit kind of calculation, and ultrasounds are they're sound waves. There's no x-rays. It's no radiation. It's very low dose. And the amount of time she's under ultrasound, it's so minimal. So there is no danger to her getting ultrasound. And especially for fertility treatment and issues, that's actually really important.
I think Taj throws up a little bit.
It's very important ultrasound is probably the most benign modality that we have, other than MRI, which is also pretty benign unless someone has a contraindication to go into an MRI machine like a pacemaker. And the only worry we have with ultrasound, which is really it's just based on is very early in pregnancy. A certain type of ultrasound wave may be damaging, but has not really been proven. But any time other than that, it's fine. And it's, again, we know not to use that kind of ultrasound in patients who are pregnant early or possibly or could be pregnant, if that makes sense. So no worries with ultrasound.
Mm-hmm. No, I didn't think there was either. But it's important. Like people think, you're going to get radiation. There was that big scare where the CT scan, where you're going for a CAT scan, was actually dosing too much for patients. And so that a couple of hospitals had that issue around the country. And then ultimately now they're always talking about low dose, CT, I think, and they check that. So that's important to distinguish. But ultrasound itself is, other than when we talk about the mammos and when Taj shows back on, those plates are always ice cold too. So that's wonderful. They have to keep the room cold because the machine can overheat with a machine. Poor machine. I mean, I get it, right? But they keep the room cold. The plates are cold. The only great thing about the ultrasound is the gel that they put on you is like
warm.
Yeah. So
except the sterile gel. The sterile gel for biopsies can be it's room temperature, but every non-sterile gel we do warm up.
Yeah.
So Sudha Parekh is asking, many women, especially in economically challenged areas, do not go for breast mammogram. And so awareness and mammos are really important. And Taj mentioned that really you should have regular mammography starting at age 40. But frankly, you should be doing breast self-exams every month. And I remember, way back in the dark ages when I was in health class in, I think, junior high school, they taught us how to do a breast self-exam. But these are really important because the data is that if we catch the breast cancer early and we treat it, the life expectancy rate really doesn't fall at all. But if it's delayed, then unfortunately this can be a catastrophic event for the woman or man, because men do have breast tissue and men do get breast cancer. We wanted to switch over and talk a bit about your work, Agnes and Taj, on health, on equity and equality in medicine and in radiology in particular. Can you tell us how you came to start Radiology Chicks and what you hope to accomplish with it?
Sure, of course. So actually, the reason that I started the group was I used to be an internal medicine doctor. I used to be a hospitalist, which there's more gender equity in, I guess, in internal medicine. I mean, there are more women in internal medicine than radiology. Then I became a radiologist, and there were no other residents at that time who were radiologists in my program. And so I felt very isolated. And although all my male co-residents were amazing, I still felt like there are certain questions I couldn't ask. I had nobody to go to. And you don't want to ask your attendings certain things, because especially early on in training, as you know, because you're kind of scared. So I started the group just with a couple friends who I knew from the military who were radiologists. And then the group just completely exploded as women added their women radiology friends and realized that there were many women radiologists who had no other women even in their practicing group or in their program. And in interventional radiology, it's particularly important because right now, only 7% of interventional radiologists are women, which is almost as bad as orthopedic surgery, neurosurgery. And there's definitely inequity in interventional radiology, how we're viewed, how women are perceived, and how we are treated. The Society of Interventional Radiology has done a lot of work. Currently, 25% of interventional radiology trainees are women. So we're definitely taking great steps to try to increase the number of women interventional radiologists.
Is there a concern for young women in childbearing age, so young physicians and nurses in the suite, because you are doing a lot of stuff with X-ray, constant X-rays like fluoroscopy, which is just a sort of a constant X-ray while you're threading that needle, for example. What precautions do you advise? And I think that's some of the advice that you might have found it difficult to ask male mentors or male colleagues. But what advice can you give for a young woman contemplating going into radiology and interventional radiology about what she should do if she plans to have a family? Oh.
I think that as far as the radiation safety concerns, we are all trained in radiation safety during our radiology training. And I think that before we get that training, there are many misconceptions about radiation and radiation safety and being pregnant and working with radiation, when you're pregnant. And we do have precautions. I wear a badge that measures how much radiation I'm exposed to. We are in the process of acquiring a new system that shows me live at that moment how much I'm getting. So sometimes maybe I need to take a step back because the further you are from the source, for example, and the more shielding I have between me and the radiation source, the less radiation I'm getting. Of course, the goal is always to achieve as low of a dose as possible. But people who are pregnant do work with radiation or near radiation. They do take extra precautions, and that is all. It's usually the first trimester where the fetus would be the most at risk. And but again, there are definitely precautions that can be taken. And also, not all of my procedures in interventional radiology are with fluoroscopy. I also do procedures with that are ultrasound guided as well.
Yeah, no, what interventional radiology has done is taking, us surgeons, we don't really want to have complications, and sometimes, especially for what I do, I'm a general surgeon. I'm in the abdomen, in the belly a lot, and once I go in and I come back out, if there's an issue like an abscess or some other thing that I need you guys to place a drain, it's much better to do that than to take the patient back to the operating room, put my little trocars in, or make a big cut. You guys have made my minimally invasive surgery more minimally invasive if there are complications, because you can generally go in and easily with a needle or place a drain and just have less tissue damage to the patient and less actual physical trauma to the patient, including probably the emotional trauma of going back under anesthesia, going back to the operating room, because our factors play into our patients and how their outcomes are. So
yep, and many of my procedures, like drains you mentioned, can be done with just moderate sedation or just local if it's truly emergent, an emergent procedure. Patient tolerated very well with just lidocaine sometimes, depending on where the abscess is, for example.
So, we're live, as I said, on all the social media channels. Please like and tag and share, because we're learning a lot from both Agnes Solberg and Kattapuram, radiologists who are spending their Sunday morning with us. There's a question from Bhargavi, who's watching from Connecticut, and she wants to know if people with dense breasts are more susceptible to cancer or higher risk of cancer, or is it because when your breasts are dense, is it harder to see an early lesion? I think that really is a question that many people are concerned about, Taj.
Taj is having an issue with her internet, I think. So, yeah. So I don't know. Do you, Agnes? Can you discuss that, or we can wait for her to come back?
I would let's switch to something else. I am not a breast imager. It is one thing that I don't do at all in my practice. Not at all.
We can go back to that, but there was a very another question about deep vein thrombosis, or DVT, and I know that interventional radiologists, when you have lots of clots that develop in your legs that are very dangerous, because if they break off and go up to your heart or your brain, you can have issues. So I know that interventional radiologists put in filters that essentially prevent those clots from getting up to the important structures. Do you do that for legs, and do you do that for arms, or do we let people walk around with a DVT for their arm, like thoracic outlet obstruction?
Yeah, so essentially, as far as the treatment of deep venous thrombosis or DVT, it's all risk versus benefit. And anticoagulation with blood thinners like Coumadin or Xarelto, etc., are really the mainstay for the treatment of deep venous thrombosis. We found that in most clinical scenarios, there is no benefit to the patients long term as far as the patients who received the blood thinners versus patients who received interventions. So most patients just get a blood thinner, and your body clears the clot on its own over time. The blood thinner keeps it from reclotting, and it keeps from these huge, bigger, I guess, chunks of breaking off and going to the lungs and causing what's called a pulmonary embolism. As far as thrombolysis or thrombectomy, either removing, breaking up the clot, or destroying it with clot busting medications, again, that's different medication than blood thinner. The clot busting medication, thrombolytics, are much more dangerous to use. We do that only in select patients who have blood clots that go all the way to the pelvis, or if the blood clot is so bad that it's obstructing the arterial flow to the leg, and now your foot or arm is at risk, or the pain is so bad that the patients just cannot tolerate it. We cannot have an adequate pain management regimen for the patient to discharge home with the blood clot. And then we would go in and either remove the clot or break up the clot in those patients. And as far as the filters, that's again a separate conversation, and we're tending to use them less, only in patients who can't tolerate blood thinners. Usually, even around the time of surgery, we're putting them in less and less. It all depends on how long they need to be off the blood thinners and etc. But there are guidelines by the ACC/AHA and Society of Interventional Radiology. There's a big multidisciplinary guideline that recently came out in the past year and a half, I believe, about IVC filters.
Yeah, I think, I've had I do a lot of weight loss surgery, and we use filters. We used to use filters in our heavier patients or higher BMI patients, and then that would be permanent. And there is a pretty high rate of complications after the filter, so that you would be at risk. It used to be like 10 to 15% of patients can develop further problems. And once you have the filter, we didn't necessarily always put them on blood thinners, but now you guys, some one of you interventional radiologists, created this removable or retrievable filter that most of the time you can just place and then remove it within like 3 to 6 months after the procedure. And I just recently saw a patient who just had her filter removed, and she was coming to see me for weight loss surgery and had a history of a blood clot after like a leg procedure, orthopedic procedure, and then developed a pulmonary embolus. So the clot broke off and went to the lung. And so she had the filter placed because they were very concerned because of her weight. So now they're taking it out and then sending her to me.
Yep, they're pretty simple to remove nowadays. I would never put in a non-retrievable filter anymore. The really permanent filters are not really indicated. I mean, you can put them in the quote unquote temporary filter. The difference is it has a little hook on top. that we can grab later. And that's really the only difference. Many of the temporary filters are also indicated to be used as quote unquote permanent filters. And there really is less and less of a distinction nowadays because we tend to remove the majority of the filters we place. Most of the interventional radiology clinics will have, we have registries, we follow up all of our patients, we ensure that the filters get removed because there are complications if the filters do stay in long term that can occur.
Right.
So we have Taj back. So we're going to pepper her with questions. Taj, there is a question about the problem of people who have dense breasts.
Yep.
And is there a concern about higher rates of cancer, or do we miss the early cancers because of the density? And then we want to talk to you about fine needle and core needle aspiration biopsies if you find a lesion.
Okay, sure. I've switched to a different, to my phone, so hopefully I can stay on. So with regards to the denser breasts, yes, the data does show that there are increased breast cancer in dense breast tissue. We're still working on exactly why this might be. Of course, it is more challenging to see through the denser breast tissue, but also something to consider is that the breast cancer starts in the glandular tissue of our breasts. And so if you have denser breasts, that means you have more fibroglandular tissue. So it could be as simple as there's more tissue for cancer to start as opposed to a fatty breast where it's pretty rare for a breast cancer to start in fat cells. And then I apologize, but what was the next question?
So we were talking about, so now you identified that lesion that even Marina could see.
Yeah.
But now you've identified the lesion.
I look at all my own x-rays, not because I'm not better, trust me, but I figure if I ordered it, I should look at it. So I've always done that. And
Absolutely. And I learn a lot when I phone back to the radiologist and we're on the phone together, each of us looking at the film, and I'm saying, but what about this and what about that?
you guys, but we're like, can we go to slide 51? Do you see 51? What do you think about that? And they're like,
just go away, lady. Yeah.
Lady, go away.
But so Taj, now you've identified this lesion, and sometimes it's cancer and sometimes it's not. So can you talk to us about how you help or you make the diagnosis with either a fine needle aspiration or maybe even an ultrasound guided core needle aspiration of that area? Can you tell us what that means in better words?
Absolutely. So when we identify a finding on a mammogram, based on its features, like the one that you guys showed with the spiculated mass that was obviously seen on the 3D, we are expecting that maybe we'll be able to find a correlating mass under ultrasound. Ultrasound guided core biopsies or fine needle aspirations are a lot easier to perform, both for the operator, me, the radiologist, and a lot easier and more tolerated for the patient, of course. If we can find the finding under ultrasound guidance, and as you can see in the images you're showing right now, we can hold the probe with one hand and use that real-time image to guide our biopsy device right up to the mass or the distortion, whatever it is. And it depends on the device. There's vacuum assisted and there's core throw devices that are spring loaded. And so, but basically it takes a core tissue sample, and that's what we can send to the pathologist to look under the microscope. As far as fine needle aspirations, those are not done as commonly anymore. If you can get a core sample for the pathologist, obviously they love more tissue. Fine needle, we tend to see that more in maybe ultrasound guided lymph node biopsies if we have a lot of vessels nearby and it might be a little bit dangerous to do a core. But as you guys know, I'm also fellowship trained as an interventional radiologist, so I have no problem using core devices in the axilla or in other parts of the body, but that might be the choice for the right radiologist who may not be as experienced or comfortable, is to use a thinner needle and just pass it a few times through the area of concern, using oftentimes suction, and hopefully a few cells of samples will be sent to the pathologist.
That's wonderful. Thank you. You really, that was gives us a lot of clarity, and having tried to do ultrasound and also do a biopsy, it's a lot of coordination. I mean, that's a lot of experience as well, no doubt. But let's switch gears a little bit. We were going to talk about in our news when we at the top of the show there's a New England Journal of Medicine article on pay equity, and I wanted to bring that up. And then, of course, we wanted to talk to you guys as well about it. And this is a study from Dr. Ganguly and colleagues, and they looked at primary care visits, right? Historically, we've always been told, in women in medicine, that listen, there's sure, you guys get paid less, but you don't work as hard, or not work as hard, excuse me, you don't work as much, right? So this is really showing you that when they looked at the number of hours that they put in, the women actually put in equal, if not more hours, where they were talking to patients about diagnoses and about what their outcomes were. Really not chit-chatting. They were actually speaking to the patient about the disease, and they are paid 87 cents to the dollar, which is outrageous. And this is something that, when I'm involved with companies, or when I go, when I've been employed, I always kind of made sure that I was paid what my colleagues were being paid, and you don't know, because there's a fair amount of secrecy involved, right? They don't really tell you. But this is something that I think across the board at many institutions are trying to institute some sort of, it's not really necessarily going to be complete transparency, but that they're addressing that inequity in pay. What have you guys experienced, and what is at Radiology Chicks doing about this? Get in there.
I think that I personally have not experienced pay inequality. My colleagues and I are pretty forward about what we get paid, and we know how much we get paid. There's no rule at my hospital that we can't talk to each other about how much we get paid, but I do know that there are other institutions where it is either very taboo to discuss pay, or it is simply not allowed to. It's in the contract that details of the contract cannot be shared with other physicians in the hospital, which I see as a huge problem. I would never work for a place like that, period. I just wouldn't sign the contract. And pay disparities are still happening. There are women in the group coming out all the time and sharing their stories about getting paid less, or being taken advantage of because they're a woman, or not being offered the same advantages as far as promotion, partnership, et cetera, because it's just assumed that we won't put in as many hours, or that we'll have to go home early to pick up a child from school, et cetera. But the bottom line is, if that people don't ask us, then we can't volunteer, right? I mean, we have to be asked. Usually the way these promotions and things happen is some guy is asked, can you do this? Can you do that? And women are just not being asked because of bias.
Taj, what's been your experience? It looked like, because I guess I stalked you a little on Twitter, or no, LinkedIn. And it looked like you started a new business during quarantine. So amazing. It's a pandemic. I'm just going to start a business. Thank you.
Yeah, my experience has been actually similar to Agnieszka. And if this is the article that I read as well, and they broke it down by profession, I believe they showed that in radiology, there really isn't much of a pay disparity. And that's because, to be honest, it's actually easier to calculate how much work someone is doing as a radiologist. Every imaging study has a relative value unit. And when you calculate for each person in the practice, you can see how much work each person is doing. It is not as subjective as other specialties such as internal medicine, where it's how much time are you spending explaining things to patients. For us, it's a little bit more cut and dry. So I have found in my experience as well that the pay has been equal and fair for both men and women. And in my most recent private practice, they were very transparent that this is what everybody makes. This is what the 40% partners make. This is what the 100% partners make. And it had absolutely nothing to do with gender. And so that's been my experience in radiology. As for my LinkedIn profile, this is why I've been having some internet issues, is I'm currently on a locums assignment, and I'm staying in a hotel doing radiology in Wisconsin. So the business that I started was basically to do my locums work. I am in the process of credentialing for a new practice, and I'll be switching to teleradiology, which will be really nice. I can work from home, and that takes a long time though. So in the meantime, I'm helping out various practices around the country. which is something I absolutely love. It's an opportunity to see various practices, various workflows, patient populations, and I also tend to learn different types of technologies and techniques as well. So it's been wonderful. So that's the business.
That's great. We're so happy. Yeah, we're so happy all the both of you could spend your this hour with us. We learned a lot. You left us wanting more. As we said in the beginning, we are commemorating Breast Cancer Awareness Month, reminding everyone, do your self-exam, make sure you have your mammogram appointment. Thursday nights, Empire State Building for October 1st was pink, and there was a full moon, and it was just incredibly gorgeous. Picture of what the Empire State Building looked like that night. Awareness is going to allow people to get diagnosed with their breast cancer early, get it treated early, and carry on with their lives. 1 in 8 women will get breast cancer. If it's caught early, the survival rate is 98%. And if it's caught late or advanced, it's only 27%. And it's a tough row to hoe if it is caught late. So everyone, please do your self-exams, get your mammogram. We want to thank Taj Kattapuram and Agnieszka Solberg for spending their time with us today. And
we want to also just, thank our producers. This is a show where, it is Suju and I, but it's really not. We have an entire team behind us. And so we want to thank them, and then also give you a little heads up on what's going to happen next week. We're going to do a show on healthy kids, and we have 2 great guests for that week. Suju, if you want to introduce them.
Sure. We are going to meet Dr. Tamara Lewis, who is an associate professor of pediatrics and a neonatology specialist taking care of the sickest babies in the neonatal intensive care unit in Kansas City. And we're going to meet Dr. Miranda Van Tilburg, who is a PhD associate professor of medicine in gastroenterology and liver disease. And she is really great about trying to teach us about the picky eater and other issues that affect our children and prevent them perhaps from being as healthy as they can be. We want to thank WBAI, which carries us on Mondays from 2 to 3 p.m. And really, thank you so much, Agnes and Taj. This has really been a wonderful time of learning and sharing experiences.
Thank you so much.
Thank you so much.
All right,
thank you.
Bye, everybody.
Bye.
Bye.